My name is Zahra Rashid. I am an optometrist working in my private practice at Gertrude's Children's Hospital in Nairobi. Thank you to OSK for giving me this opportunity to talk to you today about the current approaches in myopia control. Myopia is the most common eye disorder in the world, with its prevalence increasing, and it is predicted that every second person we meet will be myopic by the year 2050. Progressive myopia is associated with increased risks of retinal detachment, cataracts, glaucoma, and even blindness. Myopia is mostly known to progress between the ages of 8 and 15 years. However, myopia can progress during the 20s as well. 400 myopia genes have been identified. The development of myopia is controlled by both environmental and genetic factors. Environmental factors such as near work and reading play an important role in the development of myopia. In addition, studies show that myopia is more common in urban areas, among professionals, educated patients, computer users, university students, and associated with increased intelligence. Ethnicity plays an important role. Myopia prevalence is high in East and South Asia, where up to 80 to 90% of high school graduates are myopic. With respect to preventing the onset of myopia, to date, outdoor time has been the only factor that has been found to be protective. So why does the eye elongate? One theory is that near work is associated with a lack of accommodation in corrected myopes, and that is insufficiently strong accommodative response to near objects, which places the plane of the best focus behind the retina, then signaling the eye to actually elongate. This optical blur is the one that causes this signaling. There is another theory, as can be seen in the image here, where you see traditional correction that is done. When an image falls, it falls on the central retina. However, the same object that we are looking at, the peripheral images that form on the retina, actually form behind the retina. And this is when we are using traditional spectacle lenses. These peripheral blurred areas in the retina actually signal elongation in the eye and then further cause myopia. Stopping the progression of myopia has the potential to positively affect quality of life and ocular health. A number of interventions, including atropine, overnight orthokeratology, special multifocal contact lenses, executive bifocal spectacle lenses, and progressive additional spectacle lenses have been shown to slow progression of myopia. Atropine has been shown to be the most effective measure. The exact mechanism by which atropine inhibits myopia progression is unknown. Multiple studies have indicated that atropine slows the elongation of the eye, not by blocking accommodation, but either via photoreceptors or inhibiting scleral growth. 3 studies have been carried out, the ATOM-1, ATOM-2, and very recently, the LAMP study, and all have shown the efficacy of low-dose atropine to stop the progression of myopia. Myopia control with 0.01% atropine can be started as young as 5 years old and should be considered where there has been an increase in myopia of greater than 0.5 diopters in less than a year. A cycloplegic and subjective refraction is required as a baseline. Always prescribe the full spectacle correction. Undercorrection has been found to cause myopia to progress. A corneal topography is not mandatory to start treatment, but would help to differentiate between myopia and keratoconus. We are seeing children as young as 5 years old with keratoconus who initially present with myopia and very mild astigmatism. The parents have to commit to a 3-year management program. The drops have to be put once a day at night for 2 years. In the 3rd year, the drops are tapered off gradually as the prescription is monitored. Dry retinoscopy should be performed every 3 months and cycloplegic refraction every 6 months. Very few side effects have been seen, such as reduced near vision, pupil dilation, or photophobia. If these occur, reading glasses can be prescribed, sunglasses and hats used when outdoors. Younger children and those with higher prescription at baseline and those whose parents are myopic may not respond to the low-dose atropine. These account for approximately 18 to 25% of patients. The dosage can be increased to twice a day or changed to 1% atropine once or twice per week. Alternatively, combination measures can be used, such as specialized contact lenses, as well as low-dose atropine. It's very important not to abruptly stop the atropine. Singapore and Taiwan continue the drops until the children are 12 and 18 years, respectively. Some children will actually have a rebound effect, where the drops will have to be started again. It is best to continue the drops until their late teens. So in my clinic, we looked at about 18 children who we have been following for 1 year, actually 17 months now, and the youngest being 5 and the oldest 16 years. Almost half are male and half are female. Majority were African. Before myopia was started, the increase in myopia was between 0.5 and 1.75 diopters. 14 did not progress. That is approximately 78% of the patients. 22% did progress, and they did progress but between 0.5 and 1 diopters within the 1.5 years. One patient's prescription actually decreased. We were not able to measure the axial length of the eye as we lacked the instrumentation. We need to increase patient and practitioner education in this area. Lifestyle advice is extremely important for every family who has a myopic child. With the COVID-19 pandemic, children have spent most of this year indoors and online. It is likely that we are going to see many more myopic children globally and even in Kenya with time. Screens are not bad. It is the amount of time that children spend on these screens without taking a break. They tend to move from one device to the other. It is important that they take frequent breaks from screens or near work. Interchange between near and distance tasks, read in good lighting, and spend time outdoors. In the past, as a child's spectacle prescription increased, the parent was asked to change their spectacles repeatedly, and the child's glasses just got thicker and thicker. This does not need to be the case anymore. There are many methods of effective myopia control available now, with low-dose atropine being most effective, easy to administer, and has been proven to be safe. It is important to screen children early for myopia, to monitor them every 6 months for progression. Any child whose myopia has progressed by more than 0.5 diopters within 1 year, myopia control should be considered to prevent progression and the associated risks of blinding eye diseases as these children grow up. Thank you very much.